giving Blinatumomab or Inotuzumab in relapsed or refractory patients with precursor B-cell ALL is always something to consider. So first of all, you have to look at CD19 or CD22 positivity. It's sometimes forgotten, but very important, of course. And after that, I always look at what kind of patient it is. So if it's a patient with central nervous system involvement, I think you might have a advantage of Inotuzumab ozogamicin. Why? Because we know that Blinatumomab in patients with CNS disease is, well, probably related to more toxicity. And therefore, I think Inotuzumab is more of convenience. Although Blinatumomab can be given once CNS is clear of blast cells. Another thing is the fact that Inotuzumab is often related to a higher grade of veno-occlusive disease, especially if you have to give more cycles of Inotuzumab. So in patients heavily pre-treated with chemotherapy, having liver enzyme disorders, or elderly, I have I normally try Blinatumomab more than Inotuzumab. And also patients who need a second transplant have a higher risk of VOD. I prefer actually Blinatumomab in these cases due to this risk. I think, and the last one I'd like to mention is the white blood cell count. So if patients have a high tumor burden with a high white blood cell count or bulky diseases, I prefer Inotuzumab because we know that the Blinatumomab is easily saturated once the blast count is very high. So probably you might prefer Inotuzumab in these cases.